So this evening, we're going to look at blood pressure threshold and recommendation as a part of our primary prevention of cardiovascular disease. How should we manage blood pressure? And we already went through hypertension guidelines. But just to recap, and basically to recap, when we talk about blood pressure, we have a definition for normal blood pressure. And normal blood pressure is a blood pressure less than 120/80. And then we have a category we call elevated blood pressure. That is blood pressure between 120 and 129 over less than 80. That's elevated. So the blood pressure is a little bit elevated. If for normal blood pressure reading, you're basically gonna promote healthy lifestyle, and then, when you encounter any patient, even if they don't have any disease condition, you're still gonna promote optimal lifestyle habits. Okay. But if they have elevated blood pressure, which is defined as a systolic blood pressure between 120 and 129 over less than 80, you're going to try non-pharmacological approach. So that's diet and exercise. So that's a class 1 indication. So patient comes with the elevated blood pressure, you're going to try that first. Then when we move into the hypertensive category now, then we have stage 1 and stage 2. Stage 1 hypertension is defined as blood pressure systolic systolic between 130 and 139, and diastolic between 80 and 89. Okay, you're gonna put these patients in the 10-year risk. Okay, the risk, you're gonna risk stratify them. So you're gonna put them in the Poole cohort equation, and you're gonna risk stratify them. All right, so someone comes with a blood pressure 130 to 139 over 80 to 89. You're going to put them in the risk, you're going to risk stratify them. So you're going to use the Poole cohort equation. And if their estimated risk, that is a 10-year risk of cardiovascular disease, is greater than equal to 10%, then you're going to do your non-pharmacological therapy, which is a class 1, and you're also going to put them on medication. Okay? If their estimated 10-year risk is less than 10%, then you will just continue with your non-pharmacological approach, which is diet and exercise. Okay? But if you put them in the Poole cohort equation and they have a risk greater than or equal to 10%, you're going to do the non-pharmacological therapy, which is diet and exercise, and you're also going to put them on medicine. You have to get that pressure down. Now, patient with stage 2 hypertension, that is defined as a systolic blood pressure greater than equal to 140 over 90. For those individuals, you're gonna right away you're gonna do the non-pharmacological therapy plus the blood pressure lowering. Okay, so that's different from your stage 1 hypertension individuals. If they're you put them in the Poole cohort, if their 10-year risk is greater than 10%, then you're going to give them medicine. If their 10-year risk is less than 10%, no medicine, just pharmacological therapy. Stage 2 hypertension, their blood pressure is a little bit higher, so you can just go ahead, in addition to the non-pharmacological, you just go ahead and put them on blood pressure medicine. Okay, all right. So that is hypertension. So to reduce or to prevent, for primary prevention, you're going to treat blood pressure as outlined right here. Okay, so if you look at the recommendations for treatment of tobacco, so remember that tobacco is one of our cigarette smoking is one of the main culprits for cardiovascular disease, and to be specific, atherosclerotic cardiovascular disease. So you have to have a fairly solid view on smoking cessation, and depend on where you are, you might have a smoking cessation program, but it's a class 1 indication. All adults should be assessed at every healthcare visit for tobacco use and their tobacco use status. So just like you would record a vital sign, blood pressure, pulse, and temperature, you're going to talk about their tobacco use. Okay? So that's a class 1 indication. Also, class 1 indication to achieve tobacco abstinence, all adults who use tobacco should be firmly advised to quit. So you have to explain to the patient, what the hills of tobacco use, what it does, and you have to explore the different avenues to treat um, tobacco abuse. Okay. Again, class 1 indication in adults who use tobacco, a combination of behavioral intervention plus drugs is recommended to maximize quit rates. So for patients who smoke, behavioral medication, behavioral intervention is very important. And then drugs, you can try drugs as well. Also, class 1, adults who use tobacco abstinence is recommended to reduce atherosclerotic cardiovascular disease. So tobacco is definitely one of the significant risk factors for coronary artery disease, well, atherosclerotic cardiovascular disease. So for a class 2A indication, to facilitate tobacco cessation, to help the patient stop smoking, it is reasonable to dedicate trained staff to tobacco treatment in every healthcare system. So, especially if you practice in a very large environment, a lot of these places have smoking cessation program. So the patient would be referred to this area of expertise, and they would go through a comprehensive program to help the patient stop smoking. And then class 3, so this is harm. Remember, secondhand smoking also uh, can give rise to atherosclerotic cardiovascular disease. So all adults and adolescents should avoid secondhand smoke exposure to reduce atherosclerotic cardiovascular disease risk. Remember, secondhand smoking is not good. So when we talk about behavioral intervention, basically is psychotherapy, that type of thing. So patient comes to you and they're smoking, you need to, if you're not qualified to do the behavioral intervention, then you need to refer them to somewhere. And, we divide it into less than 3 minutes, status assessment with cessation counseling at each clinic encounter. So you can do less than 3 minutes, or you can do between 3 and 10 minutes. You're going to do, the assessment, tobacco status assessment with cessation counseling. And then you can also do more than 10 minutes. Depends on, the level of involvement that you think the patient needs. Now, so that's behavioral therapy. And again, if you're not qualified to do that, then you can refer the patient to someone who specializes in that area. Now, we have what we call nicotine replacement therapy. So one of the reasons why patients crave tobacco is because of the nicotine. So you can try nicotine replacement therapy. We have the patch, so we can put on a patch, and the patch comes in different strengths. You have 21 milligrams, 14, or 7 milligrams. So if the patient smokes more than 10 cigarettes per day, you try the 21 milligram patch. If the patient smokes less than 10 cigarettes per day, then you try the 14 milligram patch. You know, be aware that you can get local irritation, um, and you may need to remove it for sleep if necessary. You also have the gum, so you can let the patient chew gum. So most of these gums have 2 milligrams to 4 milligrams of nicotine, and you can start with 4 milligrams if the first tobacco use is less than 30 minutes after the patient wakes up. You know, they crave for a cigarette and they smoke less than 30 minutes. They use the 4 milligram gum. 2 milligrams if the first tobacco use is more than 30 minutes after waking. You also have lozenges, 2 milligrams and 4 milligrams. And you can see some of the problem with the gums and lozenges is the hiccups, dyspepsia, and you know, you can use other products if they have problems with the gum or lozenges. You also have nicotine replacement therapy, the nasal spray, 10 milligrams per ml, and we have starting dose. You can get local irritation in the nostrils. You also have oral inhaler, you know, 10 milligrams cartridge, and the patient can puff on it. You try to stay away from the oral inhaler if the patient have something like asthma. So these are some of the nicotine replacement therapy. So you have the patch, you have the gum, you have the lozenges, nasal spray, the oral. If you're going to put a patient in that, you just look up dose, and you know, for that particular patient, depending on how much smoking they do, and you just put them on it. No, so we have medications. These are not nicotine replacement therapy. We have Zyban, we call that Wellbutrin or bupropion, and the usual dose is 150 milligrams per day of the slow release preparation, or you can do 150 milligrams twice per day for this the for the non-slow release formulation. So Wellbutrin is a very popular medication used to treat smoking cessation. However, you're gonna avoid in patients who have a history of seizures, if they have eating disorders, or if they're taking monoamine oxidase inhibitors. So that's Wellbutrin. The one that is probably, I would say, the most effective really is the Chantix. Most studies have shown that Chantix is probably the most effective of the smoking cessation therapy in terms of nicotine replacement therapy and other pharmacological therapy. The Chantix, which is varenicline, and the dose of Chantix is 0.5 to 1 milligrams. And it usually comes in a pre-pack, so you don't have to remember the dosing. So it's usually 0.5 milligram once per day for 3 days, then 0.5 milligrams twice daily for 4 days, then 1 milligram twice daily. So the starting pack will come with these doses already packed out in the medication. And after about 3 to 6 months, a lot of patients quit smoking. Some of the problem with Chantix is the nausea. You have to dose depending on the patient kidney function, renal function. So that is Chantix. So cigarette smoking again is very crucial in our primary prevention of cardiovascular disease. So, we should have some type of understanding how to treat tobacco abuse. Again, as we said, you have counseling, um, or you can go straight to nicotine replacement therapy or the medications that we use. Now, we mentioned aspirin, and aspirin is not a very favorable medication in the primary prevention of cardiovascular disease. If you're considering aspirin use for primary prevention, you should put the patient in the pool cohort equation. So you're gonna put them in the equation, you Google it, pull it up, and you put them. So aspirin only has a class 2B indication, no class 1 indication for aspirin anymore for primary prevention. And the class 2B indication, low dose aspirin, which is 75 to 100 milligram daily, might be considered for primary prevention of atherosclerotic cardiovascular disease among select adults age 40 to 70 years of age who are at higher risk. So we're talking, these have to be higher risk individuals, risk greater than or equal to 20%, but not at increased bleeding. So they can't have an increased risk of bleeding. So, and it's only a 2B indication. So routine use of aspirin for primary prevention of atherosclerotic cardiovascular disease is no longer in vogue, okay? It does have a 2B indication for high-risk individuals who have who are not at increased risk of bleeding. Okay, so it can cause harm. So it's a class 3 indication. Low dose aspirin, which is 75 to 100 milligram daily, should not be administered on a routine basis for primary prevention of atherosclerotic cardiovascular disease if the patient is older than 70. So if the patient is over 70, do not routinely give aspirin for primary prevention. Also, class 3, it may cause harm. Low-dose aspirin should not be administered for primary prevention of atherosclerotic cardiovascular disease among adults of any age who are at increased risk of bleeding. So if the patient have an increased risk of bleeding, you're not going to give them aspirin, period. No aspirin. Okay? So that concludes the primary prevention of atherosclerotic cardiovascular disease. And again, it's very important to have an understanding how to approach primary prevention. And there are still some physicians who continue to give aspirin for primary prevention. That is because they're not following the guidelines. So we're going to stop here. And so next year, so Merry Christmas, Happy New Year's to everybody. Next year, for the first few months, we're going to do the revision for those people who are going to sit the exams. So we'll do 2 to 3 month revision where we try to go over everything, so that people who are going to sit the registry exam will have a good chance of being successful. Okay? All right. So